Great. So I get to be the very last talk of the day, which is, I guess it's better than being the 4 o'clock talk. A lot of great things have been said today, and I think what I've noticed is that everyone's been, I think, very straightforward about, I think, some of the challenges in telehealth today that often I don't hear. So that's been kind of pleasing to say, to be here. I want to give you a little bit of my background. I really got involved in telehealth back in about 2004 after my residency, and the program that I've extended since 2004 has been a maritime telehealth program. So really serving patients who are in an extremely austere environment. You know, when you talked about, someone mentioned this morning, access or convenience, these are patients who have no access because they could be days away from care or, you know, be near care that's very inadequate. And so we've been doing that since actually 1989. And at that time, we were highlighting the fact that people could reach us through a technology called Telex, which actually I don't know what that is. It's so old. But now we focus our austere environment access through telephone and email most of the time, and in a small percentage of cases, real-time video. And a lot of that is due to the fact that our clients are in those austere environments and rely on satellite connections, which are really costly for them to use video. And so the solutions we choose have different requirements than you might choose in a domestic environment. The other thing that we do in austere environment medicine is we have a different reimbursement model that we're dependent on here. So we've heard about integrated delivery models and how telehealth fits there. In my day-to-day practice here at GW, I live in a fee-for-service model, and in my maritime telehealth, I live in a subscription model. You could almost call it a concierge model, where we don't want our clients to be limited in how they reach us. We want them to call anytime and as much as possible so that we can make sure they get adequate care given the scenarios that they're in. So it's just interesting. What's been interesting for me is now to take all of those lessons we've learned over 30 years or my last 15 years and try to apply those to what I call kind of local, regional, and domestic telehealth that fits within the fee-for-service paradigm and as we evolve to these bundled and kind of other new models of care. So, you know, given this day so far, it's really hard to say new things. I don't want to be redundant. I want to add a couple other comments. One is we mentioned video visits just now, and I think the data was really, really interesting. And then I alluded to the fact that the majority of the work we do is in phone and email, so probably less than 10% of our consults are video. And I was just walking, I think, to put my coat away, and I noticed a little graphic over there that said that Kaiser did 80 million telehealth visits, but 65,000 video visits. And so we're talking a lot about video visits, which are driven by, probably not in the integrated delivery network perspective, but in the world I live with, which is fee-for-service, driven by reimbursement, where audio video is a requirement for reimbursement. And so most patients may not need video, and you know, people are extending the concept of, well, what is telehealth? Is it text messaging? Is it remote patient monitoring? Is it something else? And my guess is that next year we'll be talking about how, within this whole digital health spectrum, how are we going to measure the efficacy of things like virtual reality and augmented reality and other emerging technologies as well. So hopefully that was not the redundant part. I'll move on to what I had prepared before. And so as I was tasked with talking a little bit more about the evidence base, I came across this 2017 bill, and honestly I don't know if this has passed or where it's in its cycle of the policy world, but the Evidence-Based Telehealth Expansion Act of 2017, and I saw bullet number 1 and bullet number 2, reduce spending under this title without reducing the quality of care. And then the second one was exactly the reverse, improve quality of care without increasing spending. So obviously the emphasis is do things better without spending any more money. And I guess we all get that, but that just means we have to find evidence to figure this out. But it's a big challenge. So, you know, Neal's already, I think, spoken about the programs at the VA, and one of the things I was tasked was just talk a little bit about cost savings. And I think, you know, we don't need to dive into the details of this component. I think on broad brushstrokes, the VA has shown that telehealth and home monitoring have large impacts on hospital admissions, and presumably even length of stay of those admissions and management of care. And so those numbers are really compelling on cost savings, at least within an integrated delivery network and with this type of specific intervention, and even cost savings with some storm-forward interventions. I think it's clear that rural community members save time, save cost of travel, and save lost wages. Like, that is extremely clear, and I think everyone understands that. What I think the literature has been a little mixed on, but we've come to the conclusion is that in CHF patients, in congestive heart failure patients, that we can reduce cost of care by doing remote telemonitoring, providing access to a nurse who can help patients manage care at home, for patients to actually monitor themselves at home. I think that is also fairly clear if implemented correctly and in the right selected patients. And I think this was alluded to earlier today, and I feel privileged to be able to share a little bit of data regarding the next bullet, and that is that you can reduce ED transfers from skilled nursing facilities, long-term care facilities, or acute rehab by using telehealth. And this was shared with me from a company called Call9. They're a startup in this space. Really interesting story regarding how they have come to understand the limited resources available, especially after hours in skilled nursing facilities, and how telehealth with an acute care provider can help to triage those cases, using also point-of-care technologies can help to potentially intervene on those cases and avoid those transfers. And the numbers here, I think, are pretty staggering. 70% of some of those visits can be deferred, or transfers can be deferred. So I think this makes a compelling argument for us to look into this area further. So then the next area to talk about is quality. And I wanted to talk about a couple of the projects I've had the privilege to work on. One was in collaboration with our nephrology group at GW. We had a CMMI innovation grant to 2012 to 2015. And we deployed remote patient monitoring and video visits for home peritoneal dialysis patients. So we were trying to be extremely strategic in our application of telehealth. We said, well, these patients meet a couple of interesting criteria. One is they live with a cycler machine at home to do their peritoneal dialysis. So they live with technology. Two, their disease process really requires them to be intensive in their home monitoring. So they need to check their weights because that impacts their cycler time. They need to check their blood pressure. They need to check their glucose. Like, these are things they do and are in general more compelled to do maybe than the average patient. And so what we did is we deployed a connected health scale, a blood pressure cuff, and a glucose monitor. We gave them extra training. We gave them access to online education, and we have a telehealth call center that supports our maritime business, and we use that to monitor their incoming biometric data and feed that to the dialysis centers and see what kind of impact that would have. And so I think the surprise was the level of adoption, but we were hoping that this selected patient population would have high adoption, and which they did. And then I think what goes along with most of the telehealth literature is that patients like doing this. They were very happy and satisfied with the intervention. What was unclear was what was the true impact on their care. And while I say that the adoption was very high, that was on the remote patient monitoring side. And on the video visit side, where we thought that patients would have the opportunity to share with us, oh, this is an emerging infection at my dialysis port site, or I have a cellulite, I have a rash here, or some other maybe visual type of complaint that we might be able to adjudicate through video. We really had very low uptake on that component of the intervention. And when we asked our participants, what was the driver for that, I think a lot of this, and we're in a new era, right? 2012 is a different world than 2017. So, but it was a lot of privacy concerns. They were concerned about the provider seeing their home, seeing the condition of their home. They were worried about, once they were connected on video, did we have kind of the peephole into their house? And a lot of that came up over and over again. And then there were also some barriers in the way this was designed, I think, that may have limited some of that use. But And then, so what we did find was that patients who monitored their biometric statistics had better control, but it did not necessarily impact across the board ED visits or hospitalizations. You can see some subsets did have improvement. The next study I'll briefly talk about is a ongoing study we're doing based on a Care First Foundation grant on telehealth, and we basically we're looking at a problem we have in our clinic. We're a multi-specialty group practice, and our overall no-show rate, especially among Medicaid patients, is quite high. It was disproportionately high, and some of our community partners refer us these specialty cases all the time, but there's numerous challenges to those patients reaching the academic center, whether it's transportation or navigating our great phone tree or some of the, trying to make an online appointment. All those things are complicated and difficult, even for me. And so we decided that we could try to implement these services in the community, and we partner with a Unity Health Center which is a federally qualified health center in DC, and we built a telehealth room, and we trained their providers to be our clinical presenters, and now the patients have an option to be referred, instead of in the traditional manner, referred to the GW clinics and make an appointment and come over. They can be referred to GW clinics but be seen in the clinic. And so far, we've seen about 75 patients. And again, patient satisfaction has been spectacular. We've seen some amazing outcomes already with our endocrinologists reducing A1Cs and being very aggressive with their care. But we really, it's way too early to tell based on the sample size, but we haven't seen massive impacts on the no-show rate. We still have, patients who don't show up for those visits. So we'll have to wait to see. But we'll be measuring no-show rates, claims, and clinical outcomes for each of those three disease processes we're looking at are hypertension, diabetes, and kidney disease. The third area I wanted to mention on the evidence-based side is something very particular to, I think, mostly emergency medicine, and that is we were interested in clinical decision support, and there was a study that was published, I think, now a couple years ago, looking at the secret shopper study. I don't know if you all are familiar with that one, where they called some of the online companies like Doctors on Demand and a couple of the others, and they kind of had a canned scenario they walked through, and they wanted to see, did the providers online meet the what the clinical guidelines would be. I think there were some problems with that study, but it was interesting that there was a lot of discrepancy, especially in certain scenarios. And so what we decided to look at was there's a clinical decision rule that ER doctors use quite often. It's called the Ottawa Ankle Rules. It's a well-validated study that if you use these rules, you can reduce the number of patients with an ankle injury who need an X-ray. And in the literature, there's a couple of studies that say, well, let's teach patients how to apply this rule for themselves, because maybe then they don't have to come in. And if you look at that, every patient thinks they need an X-ray. It's very hard for a patient to apply this rule themselves. So we decided we would design a study where a clinical provider through telehealth would apply the rule with the patient, help guide them through that, and then they would go through our normal process in our ED, and the ED doc would commit to the same set of Ottawa Ankle Rules, and then we would look at how these compared. And so far, we haven't met yet our power goal, but this is how it looks. The doctor on one side, they'll help us examine the ankle. We walk through the 5 steps, but so far it's been great. We've had about 60 patients enrolled, and the CAPAs, where we're looking at inter-rater reliability between the telehealth provider and the in-person provider, have been extremely high. And so I think this is going to show, presumably this will eventually show that this rule can be applied through telehealth as it is applied in person. But I think there's a whole series, this is a gap in the literature, there's a whole series of types of things that we do every day, or rules that we as physicians or providers apply every day that yet have not been validated through telehealth and probably should be. And so we're looking at that. But it also depends on what your comparator is. And I don't want to belittle the value in saying, hey, if you're comparing this to no care at all, maybe it doesn't matter. But as we get more sophisticated in our application of telehealth, then it does matter, and quality is a big driver. And this is one of those kind of questions we can address. When I looked at gaps, I think we've talked a lot about the integrated delivery network, and we've alluded to the fee-for-service world, and how does a small practice or an individual provider apply telehealth? I think it's a hard use case unless they're in a rural area or they have some other driver, they know their patients have this need and they can somehow put it into the workflow. And I think studying that is important. A couple comments I wanted to make before I run out of time is the efficiency of the traditional workflow. And what we've learned through some of these projects are that when we do telehealth, and especially when we partner with facilities that are in the community, we're often just putting in our normal workflow into that facility, right? And so are we taking away the services they were providing in person? And so we need to really look at that carefully and try to understand. We don't want to be replacing one for one. We need to figure out how we can scale a telehealth into the community so it adds value, especially when we're looking at underserved populations. So things we're brainstorming are how do we train new clinical presenters so we're not taking a nurse out of the fold to do telehealth when they should be seeing patients, and we can bring maybe a community member or a community health worker or someone else who can serve in that role. And same when you think about locations, taking space from an existing in-person clinic and repurposing it for telehealth may not be the right choice. But again, it depends on what your comparators are. So clinical decision rules, obviously a passion of mine that I just discussed, and looking at standalone telehealth versus system-based telehealth, of course, is a big question. So training is another thing we brought up, and I think the question of how do we train our providers, and then how do we measure how good they are at providing telehealth, again, as we become more sophisticated, are going to be other important gaps that we need to address. Thank you.